Should we
Please start.
continue?
Yeah, please start. Thank you.
Resident of and hailing from Nepal, brought by and informed by mother, who is reliable, came with complaint of bluish discoloration of lips and fingertips since 1.5 years.
Yes, ma'am, you are audible clearly. Please go ahead.
Parents observed that the child was apparently alright till 6 months of age, then started observing having duskiness in the lips and fingers of both hands and legs, which used to aggravate on crying and reduce on rest. For this, they took the child to some local practitioner, told to have a malnourishment and symptomatic treatment was given. As the child grew and started walking, parents observed that child used to have increased bluish discoloration and fatigue on walking or running some distance, which is usually less than 100 meters. Following which child used to sit down in squatting position and thus get some relief. There is a history of non-given weight compared to other siblings. There is no history of sugar subcycle, no history of excessive food weight sweating during feeding, no history of critical cholesterol requiring medicines, no history of seizures and convulsion, no history of swelling over the body, no history of similar complaints in the sibling, no history of family, no family history of any heart disease.
मैम सॉरी टू
Uh,
डिस्टर्ब यू माइक थोड़ा दूर पकड़िएगा
थोड़ा दूर. Okay.
थोड़ा दूर या थैंक यू
Okay. There was no past admissions. ANC and birth were uneventful, and child was immunized till date as per national immunization schedule. Developmentally, gross motor, the child runs and goes up and down the stairs. Although child used to squat during this. Fine motor, the child can draw a circle. Language, the child can speak three-word sentences, and social plays with peer. Impression is appropriate for age. Dietary wise, the total calorie intake is 1020 kilocalorie. Required is 1200, which makes a deficit of 180 kilocalorie, whereas there is no protein deficit. There is no significant family history. So
So at 6 months, this parents observed that this child started showing duskiness of lips and fingers of both hands, which used to aggravate on crying. Okay? So what would be your thoughts at that time? Come here, because maybe we have some issues with the sound for that time. So you parents have brought a 6 month old baby to you, saying that the baby becomes blue while crying. What would be your first thought?
this is your blackboard.
Very good. So that only is one thing that will come to your mind. And this is also, so you have to decide. How do you decide whether it's a bad or not? This is in history. It means there is a diagnosis on accurate history. So that is the nature. So we have to child we do to begin with sunscreen. Then what happens?
When there is
So at the peak of time, what happens? It happens to the current. So this sound of current will go away. It will be silence. That is the time the baby will become blue. Right? And then the cry will come back and the blue will go away. So this is the history of breath holding step. You would clarify that and she might say that it was reduced on rest, but it was still there. Right? So now you are saying this is cyanosis, this is not breath holding. So now is it respiratory or cardiac? How do you decide that? You are still on history, not examination.
because of the central silence of the lips the condition, it was not resolved, so there is no history of any top cold or any respiratory illness in the society.
So it would be better than that. So first of all, you said because it is central. So is respiratory cyanosis not central? That is also central. And in it is central. Which is the peripheral cyanosis that you are aware of? Okay, macro cyanosis in a newborn. Right? So what does that mean? What happens in macro cyanosis?
On exposure to cold, there is vasoconstriction. On exposure to cold, there is vasoconstriction.
But what happens to the chemical areas, the tongue and the lips? No change. Okay? So central cyanosis is respiratory or cardiac path. So that is not the reason why it is not respiratory. Okay? So in respiratory, when will the acute respiratory condition give cyanosis? And what is the difference with the chronic respiratory condition giving cyanosis? Alcohol is to be in the main gateway, in the trachea. There is one kilo, so why should there be cyanosis? When does a pneumonia get cyanosis? Okay, bacterial pneumonia. When do we get cyanosis? When we get cyanosis in terms of timetable on day one or on day three, mild or severe, I'm asking in that sense. So acute respiratory conditions give cyanosis is as a pre-terminal event when it is respiratory failure, which means the child has to be very sick and breathless. Okay? So that is acute respiratory, which is chronic respiratory condition which can give rise to cyanosis. Give an example. Interstitial lung disease. Very good. Now try to tell us what will be the history of the interstitial lung disease cyanosis and what will be the history of the cardiac cyanosis. How will it be selected?
Distance near any factory.
That is the etiology. But what will be the history of cyanosis which will tell you this is respiratory? Very good. Gradual over
Period of time.
weeks, months. Then second, it's not necessary. Congenital heart disease is also over weeks and months.
And you will explain there is cough, cold, and symptoms. Respiratory.
Anything else?
Chronic interstitial lung disease, interstitial lung disease presents rarely with cyanosis. It presents with the first symptom is when exercise intolerance. When exercise intolerance comes, the patient knows that he has to stop now and prevent further worsening hypoxia. So, a small degree of hypoxia, clubbing, was still cyanosis, and then the child was put down and avoid further death. Of course, as the disease worsens, you might find that he is almost bedridden with cyanosis. So, in this case, we would use one term to tell the examiner that it is nothing but cardiac, and that is a comfortable child with cyanosis. Rest all of them are uncomfortable. Okay. To use the term comfortable cyanosis. Now the question is, could it be a chronic mucopolymia? This is another cause of cyanosis. And mucopolymia, congenital is not common. When it is congenital, would have come up very early. Right at birth. And then after it is acquired, it's like all of a sudden with some exposure to chemicals. And therefore it's not chronic. And to that extent, this is just a cardiac cyanosis only. Peripheral is out, central respiratory is out, and therefore this is very much a thing. But now, I think that cardiac cyanosis is a permanent cyanosis. You might say it increases on cardiac. Why is that? So why should the cardiac cyanosis increase on cardiac? It should be stable over the time. What's your take on that? So in other words, in cardiac physiology, what happens when child cries? And thoughts?
Ischemic vascularitis increases.
Very good. It falls. Doesn't increase, it falls. So what happens? Okay, so one thing is that the demand increases. So because demand increases, cardiac output has to increase. That is one thing. Now, systemic vascular resistance falls. Okay, so what happens because of that?
Pulmonary will overcome pulmonary resistance.
Is the same.
So the blood will flow from right to left.
Very good. So, for just for understanding sake, I am using this number. Suppose the cardiac output was originally 3 liters. Now the child is coming. So we have to make the cardiac output 4 liters. So the heart starts pumping more. But because the vascular resistance has fallen and the pulmonary resistance is the same, the extra blood which the heart is pumping is going across the shunt into the systemic circulation because the resistance is smaller. So the amount that is going to the lung to get oxygenated has not increased, but the demand has increased. So that is why you end up with more signs. Understood this? Okay? So we started with means non-cyanotic conditions, cyanosis, respiratory, now we have come down to cardiac. Now we have to decide whether in this child, whether it was cyanotic heart disease, you have to decide first whether it is congenital cyanotic or it was acyanotic which became cyanotic. What is the term? Amdekars. So do you think this is the second one, second situation? Why not? But you have to justify it properly.
And there is it is a chronic condition and there is increased pulmonary pressure. That's why the flow is reversed. And this is the beginning of the disease is at the 6 months of age. It is very early in the age before that happens.
So one is age-wise, means 6 months, one is very early. First thing I can remember, first the history will be of a left to right for the first few months. So there is a repeat of restlessness, low respiratory problems, repeated failures. Then slowly that will get into hypertension and reverse. So that history is not here. So this is not SN marriage. It is congenital synoptic heart disease. Okay. Now, in that, then you have to decide whether it is decreased pulmonary blood flow or increased pulmonary blood flow. How do you decide?
There was cardiac requiring admission. There was no stroke, subject, subcycle, or any signs of the stroke following right sided failure or tissue.
So there is no history to suggest pulmonary and that is one thing that she suggests. What else is there here which tells you that it is decreased pulmonary blood? What is the fatigue on walking and running mean? So partly we just discussed, so now take it further. What does that fatigue on walking and running mean? Why? You're right. Why? So because he's walking, he needs more. He is not getting more. So he is getting fatigue. Which means, suppose it was high pulmonary blood flow setting, and with the increase in cardiac output, which we just discussed, most people will have gone to pulmonary circuit. No, pulmonary blood is not going, he is feeling fatigue. So it is low pulmonary blood flow. And it's one reason, of course, which you get. Right? In the second group, increased pulmonary blood flow, again you have two subdivisions. One is parallel circulation. Example, which condition has parallel circulation? Cyanotic heart disease, which condition has parallel circulation?
Transposition of blood.
Very good. So transposition, that is one another increased pulmonary blood flow in two categories. One is parallel circulation. Implemented by transposition, clinically, they will become cyanotic and mild deep. So deep sinuses right from birth is parallel circulation. Okay? And the second category is mixture of blood, which leads to cyanosis and failure. So you have oxygenated and deoxygenated blood mixing somewhere. Okay? And it is a high flow setting, so failure. So example, which condition? Very good. Or what is low pulmonary blood? So truncus arteriosus, single ventricle, they're both. So truncus means both the aorta and pulmonary ventricle, one big vessel. Similarly, single ventricle is one big chamber in which water. So blood is getting mixed. Right? So there you will have mild cyanosis and failure. So now to summarize all this, to make it very simple, you have deep cyanosis right from birth, parallel circulation, PGA physiology. Whatever may be the additions to that, you have mild cyanosis with symptoms of failure, you have a mixing circulation, single ventricle, truncus, etc. etc. You have a slowly onset progressive cyanosis, it is low pulmonary blood flow of physiology. These are the three clinical categories. Okay? So this one is which one? Of physiology. Very good.
I think basics now is clear, but there is something more that depends on what is the pulmonary circulation. For example, salutes, looking at one extreme of clean salutes. We can see not having cirrhosis. Why is that? The clean salutes in between The cyanosis is getting worse by time, and the other extreme, both becomes cyanosis. What is this difference in the manifestation? These things are clear. Circulation mixing, now, in the first two groups, ultimately the presentation will be decided by the pulmonary obstruction, degree of obstruction. So what is coming again balance? You can balance between. That means a cyanotic. You should balance is the cyanotic part.
Think, you know the answer. So what is causing the cyanosis in parrots? What is it? Let's understand it. It's not for exam, but you have to understand. What is causing the cyanosis in parrots? Why is this happening?
ESD, there is ESD.
So normal ASD also is there. No, why that is not right to it?
Pulmonary stenosis.
So the pulmonary blood flow is over a compound. And when there is presence of ocean, that is the second component. So less blood is getting oxygenated and more blood is going to the systemic again without getting oxygen. It should have gone to the lungs, got oxygenated and come back. But even before that only it is going. That is why we are getting cyanosis. So now sir is asking why do you get a pink fellow? So what changing physiology will make this person less cyanosed or not cyanosed? In what we just think about. I want you to think. So one is less degree of pulmonary stenosis, right? Now think further. What else can make it less cyanosed? Obviously will not really make a big difference. So one is that your obstruction only is less, which means enough blood is going to the surface. Is there any other way enough blood can go to the pulmonary surface?
PDA.
So PDA will depend on pressures. So depending on which side pressure is more, blood will flow from pulmonary to aorta, aorta to pulmonary. Right? That is totally pressure dependent. Anything else which can increase blood flow to pulmonary surface? Collaterals. Okay? So there are some fellows who have a lot of collateral blood vessels which take blood to the pulmonary circuit, and that is why there is enough oxygenation, and that is why they don't show as that.
And I think when we call it pumping fellows, it's clinically pink fellows. When you look at this oxygen saturation, it's not normal. But it is at a level where radiation cannot. What is that level of oxygen concentration? When there is no concentration, but we need to diagnosis has not yet happened.
When you see cyanosis, what is the SpO2? What is the first SpO2 at which you and I will see cyanosis? 85. Okay? And what is normal SpO2? 94, 95. So this window is what sir is explaining, that those pink arrows may be 88 or 90. He is much lower than not. But he is not showing us.
Nobody know that. There is no cyanosis. You could call it a cyanotic condition. So then other findings are there with a little lower oxygen concentration, not enough for cyanosis to see. There is an hypoxia. Okay. But not a degree that will be obviously seen as cyanosis. So what would that happen? So clubbing makes that happen. We talked about in the C-cell disease. So generally, this is just to explain and understand everything. Normally, most of these things don't happen the way we are explaining. Okay. most of them will have a silo cell clubbing altogether. But this is one way where there could be clubbing and not silos. Any other conditions in relation where there is clubbing but no silos? There is chemical conditions? No. No. Okay. And therefore, that could it there be a silosis without clubbing? These conditions? Excellent. Okay.
So we've understood all this and we've understood why this is the low vulnerable flow. So we're expecting paradox. Okay. So now on history, you have to start thinking like this every time. Okay. Not wait for your findings or your investigations and then only attempt to diagnose. Now not gaining weight compared to other things. So what will be your mind thought process? 6-month-old or 2-year-old is not gaining weight compared to other siblings. First question in your mind will be onset, okay, when did it start? Second, in other words, you will first judge the dietary adequacy. Okay, as a answer, always remember, first you will decide is he getting enough. If he is getting enough food but still not putting on weight, then it is due to the disease. So that concept decides the dietary adequacy.
But if he is having enough nutrition, then he is resting. Everything that comes failure of your weight, eating enough, not drinking. So this is the problem. So can enough nutrition still be not enough? That is because the output of energy is not. And when that is located, you will not get. So this is a sort of energy output, but not input has a limitation, but output has no limitation. So you could have all such things. So tell us, why are you talking about PVC?
Age of onset was delayed for 6 months. On examination, the child was afibrile with a heart rate of 120 or of 30 per minute. Peripheral pulses and central pulses were felt, extremities were warm. Saturation was recorded as 80% in all 4 limbs. Then anthropometrical impression was the weight of the child is 9.4 kg, whereas expected is 14 kgs, which is -3 standard deviation. 86 centimeter, expected is 94.8, which is between -2 to -3 standard deviation. Head circumference is 46.5 centimeter, expected is 49.3, which is between -1 to -2. MAH is 12.5, which is -2 to -3.
Show that. Here, here.
So interpret this correctly. Wait. Interpret this correctly. So you said -3, all that we understood. Yeah, tell me, is the weight affected? Is the health affected? Which is affected more? Tell me that.
Weight is affected.
Both. So that's the pattern of chronic malnutrition or chronic systemic disease. Okay. What is the red small? Very good. Say loudly. So again want to reinforce that -1 to -2 SB is normal. Up to -2 SB is normal. So just because it is -2, think it is abnormal. Okay? Good.
On head to toe examination, cyanosis is present, central cyanosis.
Child is here.
Yes.
Child is here. Call.
It comes again normal. And it is moving comes again.
तो बहुत ना दे हम बैठो इधर नीचे ये चुप ये बस ने मजा ले ये इधर ला ले
What the दूसरे में comes again.
General could be hungry, maybe Palagram.
Behavioral disorder.
Where do the infants get into comes again? You have a habit, right? Is it normal in infants? Yes. Then how can it be normal? So why is it normal like that? Does it serve any purpose?
They are used to sexual.
meaning period. So when what is mouthing?
Anything comes to their mind, anything anything that comes to their head, they put it in their mouth. So they basically, this comes because they have to get reduce their like so that when complementary snacks, then it will be easier for the kid to take the complementary.
I think it serves a lot of purpose. For example, the child is exploring everything. So whatever he gets, he doesn't know whether it can make sound, he cannot see the color and appreciate it, but he can always taste it. So he starts tasting food. And then gradually it gives the child some comfort and relief. So in every stressful situation, he wants to relieve his stress by taking away his mind from stress. So the tongue goes into the mouth, like the executives when they are stressed, smoke and so you have to have some relieving situation. It also helps now. For example, even you are busy, your mind blind, you are mentally gathered. Food always goes to the mouth and not to the nose. What a good coordination. Okay, so it serves a lot of purpose. But obviously, once the child knows that there are many ways of exploring objects, then there is no need to put them. Right?
Okay, one by one, everyone give one finding.
First
Observation. So we just make a habit.
And then announcements when you think of it. Almost.
Okay.
The gray color here.
Very good. Okay.
start with the system. You don't think that development, but a normal looks like. And then go from micro to almost. Even observations so that you do this. So you start trying that. You have nutrition development.
Just visually, how does it look like?
Appear small for a
So you will say poor growth, you will say average, or you will say good growth.
average.
Good.
Very good. So when you are talking about good, look at the nutrition as well. Okay, nutrition muscle mass Okay, reasonably fat everywhere. Surely the child is looking alert and normal, so the growth is average, maybe a little less than just, but many other causes. Development will look normal. Nutrition average maybe a little less. But the hairs are sparse, so there must be a protein malnutrition. Which cause of agree?
I was very happy to see you from answer, sir. Hey, so sir is saying that brown hair, so sparse hair, so protein malnutrition. He's pricking you. So answer what is the catch? Okay. What about the other? Okay, so other signs are not there. What else?
There is no baggy pant.
Well, that's okay.
Alternate. No,
That is flag sign. That is different. So these children with kwashiorkor who have that um, sparse hair and brown hair, how do they look? What is their behavior?
Behavior is to first change it. Okay. This one is very alert, looking around everything, right?
Asthenic fishes.
So, Dimple, first of all, we always teach that though your books and everything you learn it as protein, energy, malnutrition, in your mind, subtract protein and calorie. Make it a habit. So always baggy pants and asthenia and all are calorie deficit. Okay? Protein is your hair changes, but mainly your behavior, apathetic. That is mainly protein.
And there are many conditions with hyperalbuminemia or like nephrotic syndrome, very severe. Diabetes, moderate. Nutritional, not so severe or moderate. Then once you get nephrotic syndrome, it's such a mental changes, skin changes. Nephrotic syndrome have 1 gram of hemoglobin. If VM may have 2.5 to cirrhosis may have similar. Do they have also the skin hair changes and medical changes? Then why is it so? So you have to become severely hypoalbuminemic not to get all those. Any thought? In other words, the signs that are getting protein deficiency, sleep deficiency. Things are related here. Aspects nutrition related. Protein to preserve the so that's what this is not. So there is a lot of things. One must be one of those. So in other words, this is normal for many. Okay. So this is, but in examination, you will find all such things, right? And similarly, many of the children have a very bad things. And that's what the sign of any basically. So this is normal for them, right?
2 मिनट के लिए उसका टी शर्ट निकाल दो इधर ही आप पेपर से बिठा के रखो खाली टी शर्ट निकाल दो एनीथिंग
Oh, suppose. Very good.
पूरा निकालेंगे निकाल दो sir is asking in such a child what else do you want to observe. We saw cyanosis clubbing, we saw comfortable child, average growth, not sick.
There must be something you want to observe, right? What should you
अच्छा जाने दो रोने okay नहीं
Dysmorphic fish.
fantastic fantastic So look for dysmorphic faces anywhere because you're looking at a congenital heart disease. So any other points, right? Good. Now you have to come to the precordium. So
anything in precordium you want to observe?
yeah.
Can you get a clue? You have to special in the silence. So that's from precordium. You have to special. Okay.
He's not alarming, he's crying. So basically now what are the findings you can tell us?
Precordial bulge. Effects in first was not visible. No other perceptions was parasinuses. Patients,
So no precordial bulge means what? Everything should have a meaning. So what does it mean? No hypertrophy. So Fallows to has hypertrophy, no right ventricle. So then why no precordial bulge? He's suffering from 6 months to 2 years. It's 1.5 years of hypertrophy.
You could auscultate and then let him go. Just auscultate and then let him go. Don't disturb him. Just auscultate. Just auscultate. नीचे रखो कोई बात नहीं शाबाश शाबाश वेरी गुड गुड
From next time, all of you carry a few chocolates. Okay? Because if you want them to allow you to examine and learn something, but okay, where systolic, diastolic.
great to but loud, loud, loud people was there.
Tell us all.
On inspection, sir, there was no precordial bulge. Apex impulse was not seen. No visible pulsation. No
Yes, you were
stars.
telling me the meaning.
Precordial bulge, there is no light.
So when you get a precordial bulge, when there is a increase in the size of the heart, what happens in Fallows is concentric hypertrophy due to pressure work. So the heart overall is not enlarged. There is a hypertrophy of the ventricle, but it is concentric, right? So that's the no precordial bulge, right? Now you will see
right ventricle is inferior. The left ventricle is lateral. Okay, and the right auricle is lateral obviously. So the ventricle is going inferiorly. So if at all when there is a cardiac hypertrophy on the right side, you will find something in the elliptic gastric. Of course, here it's not a volume overload, so you will not be paying. So that's why even when there is a hypertrophy of the ventricle, you don't have any condition. Right?
you said apex impulse is not seen. Means what? Anti-eruption. It's from the left side, right side. It's so cardiac. So you will see one dextrocardia in 30-40 years in people, there also apex will be absent. So you have to look on the other side. Okay.
Then on television set, the big screen was popular and full television space light and not regular light. There was no Palestinian game or Consultation as soon as two was present, there was a lot of to and cultural area and no resistance. So,
So when you say palpable P2, first of all, we should not say because so what is the second art song made up of? So how do we know on palpation that this is P2? Yeah. So on palpation you don't know that it is P2 and it is not A2. So you have to just say second art song is palpable, right? And then when you auscultate and you said that there's a loud P2. So first of all, before that, what is more important in cyanotic art disease that you have to say? Do we get a split or we don't get a split?
if there is a volume overload, then we get this.
So in general, as a rule, most cyanotic art diseases have a single second art sound. And why is that? What are the I mean, how do you generate the second art sound? Closure of which valve? Correct. And that valve closure depends on what? Volume of blood flow. Fantastic. So here we discussed that less blood is going in the pulmonary circuit. There is less flow. So the valve closes very softly. So the pulmonary component is not heard only. It is a single heart sound where the pulmonary component is not heard because the flow is very disconnected. Right? So in cyanotic heart disease, make it a habit to say that the second heart sound is single. Okay? That split is important. Now the question is why should it be palpable? Generally, when we say palpable second heart sound, what do we mean in other situations? Or in rheumatic heart disease, what do we mean? Palpable P2 means what?
Pressure.
No, so lot of pressure. So pulmonary hypertension is what is the commonest cause of loud P2. So here, are we saying that there is a high pressure that is why H2 is low? No. So one of the causes of loudness is a thin chest wall. In a cyanotic heart disease, when you get a loud sound, you shouldn't call it that the pressure is high. Maybe mostly it is just a thin chest wall. So now
No murmur.
you said no murmur, and he said there's a murmur. You said there's a soft murmur. So now, doesn't matter. So how will you construct your diagnosis?
No murmur is no shunt.
Pulmonary stenosis can also have its own murmur.
Correct. So now, what are your findings? Let's enumerate. You got cyanosis, working, and heart findings. What do we have?
No cardiomegaly.
So no cardiomegaly is a finding here. No cardiomegaly is a finding. Then, okay. Yeah, so no murmur. So now you could answer the first question. No murmur means no shut. Right or wrong?
If it is a large,
Very good. So it could be a large non-restrictive defect which will not give rise to a murmur.
That's what you know. Even in you and me, there is no murmur. But you said large flow. Nobody also goes on that,
So, how will you construct this diagnosis? You will say that this child has cyanosis, which you have argued that it is cardiac. And we have said now findings are no cardiomegaly and no more. So first we bring in that there is possibly less pulmonary blood flow. That is why, because if there would have been more pulmonary blood flow, then we would have had dilated pulmonary arteries, pulsations, this, that, all that we are not having. So therefore we will say that uh, the very fact that there is cyanosis and without an enlarged heart, without any signs of epidemic circulation and the history suggests that there is some pulmonary obstruction. Right? Obstruction to right group line. This blood is going into the pulmonary circuit. Now we say, though it is normal, this blood is getting shunted into the systemic circulation. Otherwise, how would you get cyanosis? So that means there is a non-restrictive step. So you already you got the second component of that. Right? First was obstruction to right outflow. Second is this one. Now you have to bring in two more components. Right? Ventricular hypertrophy for which you have no signs. You know, paracetamol, you know, epigastric pulsations. So that remains. And overwhelming. So how do you bring in the overwhelming? So suppose now a ventricle has to keep pumping the register of options. What can happen over time? And failure. So why do these children don't go like it? Very good. Fantastic. Because of the other opening, the aorta. So this is the way you bring in the override. So this is the way you construct your diagnosis. So don't just say that. Which is true, this is possibly four things and therefore diagnosis is yeah, so we don't have it, but we have the other elements. So you assume that that is there.
in daycare, you know, yellow normal. The people is not as we said. Then where is the cardiac disease? My diagnosis is a polycythemia. Because of polycythemia, there would be cyanosis. Okay. Then it's not a heart disease at all. No, you are no normal. Why are you bringing in cardiac disease at all? This must be polycythemia. And when there is a high level of polycythemia, you will have a cyanosis. And the cause of polycythemia may be even a renal disorder. Okay, not a very property. So how do you convince me that no, how can it be polycythemia? After the correct question, you would have said, but efficient is Don't forget about it. History says in another regard, absence of polycythemia and we will discuss. So that's why just keep that in mind. First in polycythemia. I've seen in 50 or 60 years old is one renal tumor which have no erythropoiesis. It is just to stimulate the pressure and you have many more pressure than him.
We did a CBC. It was suggestive of polycythemia because of the chronic hypoxia and we did a 2D echo. It is a provisional reversal, which is a list of the top people.
Yeah. You said pulmonary stenosis, right? So if suppose you said there is a murmur, you said there's a faint murmur in this chest, that murmur is across the VSD or it is across the right ventricular outflow? If there is a murmur in this or any other side, where is that? It is never across the VSD because as you all of you said, VSD is very large. It is non-restricted. So that murmur is always across the outflow tract. And that's why it's like a ejection systolic type of a murmur. Okay? So that is one. Other question in exam is pulmonary stenosis a sign of the heart disease? Only pulmonary stenosis. No, why? There's no sending, there's no mixing of blood, there's no deoxygenated blood going to the systemic side. So pulmonary stenosis is external to pulmonary flow. But there is no way that blood is going to the systemic side. So isolated pulmonary stenosis is not a sign of the heart. Then if you're doing well, gold medal, the examiner will ask you PS with PSP. Is it a sign of the heart? No, it depends on the pressure. So usually PS with VSC. The VSC is not a large unrestricted thing. It's a small VSC. The systemic pressures are always high. So it is always left to right shunt rather than right to left. So because of the pulmonary stenosis, right-sided pressure is little higher than normal, but it is still not suprasystem. Understood? So in all these heart diseases, all flows are decided by the pressures, right? So that's the catch that their pH with VSD is also not a cyanotic by itself because VSD is small. Yeah.
So you mentioned one point now, if there is pulmonary stenosis, that there is no oxygenation happening of the blood.
So no, it is less.
Through the collaterals.
That is good. No, that itself will cause violence, but not cyanosis. Whatever, see, the difference between a pure pulmonary stenosis patient and this fellow patient is that what is the blood which is reaching the tissues in this fellow patient, the blood which is reaching the tissues is deoxygenated plus oxygenated blood, shunted blood. So the PO2 of that blood which is reaching the tissues is pretty low. Right? So that is why cyanosis. Therefore, if pulmonary circulation is getting less blood flow, little less because of the stenosis, that is all oxygenated and that is coming to the heart and then again going to the aorta and everywhere. So what is going is 100% oxygenated. Right? So that's our paper. Next, please.
Corrective surgery.
Okay. Okay, how will you make this check?
Corrective surgery.
Corrective surgery in future means you have to wait for a long time, or when can we do it?
You have to do it before isolation sets into time.
This one will not Eisenmengerize, but this one will get into a lot of other complications, right? In
Says
fact, you should do it very early. Yeah. Oh,
Year-old male child forced by birth order, born out of non-consanguineous marriage, resident of Govandi hailing from UP, Sheikh by community, Muslim by religion, brought by and informed by father with complaints of abdominal distension since 15 days, fever since 10 days, bilateral lower limb swelling since 5 to 6 days, and yellowish discoloration of eyes since 7 days. The abdominal distension was insidious, gradually progressive, and generalized. Bilateral lower limb swelling, it was present bilaterally, initially involving the feet and progressed over a period of 5 to 6 days to extend up to bilateral knees. The fever was acute in onset. 2 to 3 undocumented spikes were present every day, high grade according to the father. For the first 3 4 days, not associated with any rash or chills. Child was active during the interfebrile period. The fever resolved with medications, and currently the child is afebrile since 4 days. The yellowish discoloration of eyes was noticed by the father in the he noticed that it is present only in the eyes and was maximum at the onset. It did not progress over the week. On probing, the father complained that the child had edema over the scrotum since 1 week. The child also had history of blood in stools, 2 episodes, small quantity, 1 week back. The child also had multiple pinpoint lesions over both upper and lower limbs and involving the trunk. They were pinkish color, which the father attributed to mosquito bites, and he did not pay attention to it. The child has a significant past history. The child has history of 3 past admissions. First, the child was admitted for loose stools 1 year back, but also told that he has some infection in the brain for which the child was treated for 10 days and then discharged. Second admission was in February 2026 in view of loose stools since 2 months. This time the loose stools had blood in it intermittently. Child underwent some procedure and was discharged after the procedure. Samples were collected during the procedure and sent for testing. The reports were not available at that time. Third admission was 1 month later in March 2026 in view of loose stools again since 10 days, and in that admission CT scan was done for the child, and father was told that the child has abdominal TB and he was started on medications for the same. The child has been taking AKT since 1.5 months now and has been asymptomatic for the last 1.5 months, and now he is presented with the above complaints. There is history of intermittent associated abdominal pain, crying during micturition, and reduced appetite. There is no history of vomiting or loose stools in this admission. Loose stools or blooding stools in this admission, facial puffiness or reduced urine output, no history of fatigue, increased work of breathing, no history of any cough, cold, or any blood transfusion, no history of bleeding from any side. Rest of the history was uneventful, but important point was during the first admission that on discharge, the parents were counseled that they should avoid milk products to the child. So then he was asymptomatic till March 2026. So for 1 year after removing milk and milk products from the diet, the child was asymptomatic. Then again he started with the symptoms of loose stools and blood in stools.
All that is over. Go back. Second. Now, because we started late today, we might go a little faster. So, what does this abdominal distension refer? Something compared to the abdominal distension. What are your thoughts on that?
systems like
in the northern western part, in the gas distribution.
So quickly, lateral extension is waxing and waning, so this is unlikely. So we are between fluid and oil, right? What do you think this is? If it is mineralized, then it is likely to be, okay? Then the cause of that. So we are
Vascular.
related or kidney related.
very good.
The abdominal distension started first, followed by renal edema. So more likely to be a renal pathology. Or second is cardiac. No patient documents were there, so renal is most likely with the on chief complaints.
So while you are right, but we also remember that cardiac never abdominal disease. You come to for breathlessness, dyspnea, exertion, palpitations, those complaints, you may find some ascites sometimes, right? So in between kidney and liver, but also a chronic risk, which is just hypertrophy. Any bit abdominal distension or ascites in culture, yeah, they come with abdominal distension as a complaint, they come here, the child has developed ascites. That is also your finding. They don't come with that complaint, right? So you may find some fluid, not the. So the minimum difference between kidney and liver would be kidney distension or abdomen happens in a dash child. What is a dash child? In the lungs. Very inside. Absolutely happy, playful, very child, and then suddenly there's distension. That is your usual floating. But it's a liver disease, abdominal distension, ascites happens in child who is chronically sick. So how was this child? You given us the past history, but from looking to now in the interim period,
The child did not have episodes of those two. He was playful. But right now he has become irritable since the admission, second admission in February. He has become irritable as compared to the condition 1 year back.
I think if we don't take into account the past history, and we are just discussing this, then the first impression is that this is not an acute onset disease. There's something happening earlier. Nobody said that what is happening earlier, cardiac is out. Okay. Could it be a renal disease? No. So could it be a liver disease? But liver disease suddenly presenting with edema and all is unusual. Liver disease would become slowly worsening and not massive. Okay. So could it be nutritional? Hospital almost never has a science. And the reason is, the scientist is seen in the target when the albumin goes down almost to 1%. Nuclear is not so good. The second is, in living disease, albumin may not be stored well. There is a portal hypertension which leads to accumulate fluid in the peritoneal cavity. You need a very low albumin and you need a moderately low albumin with portal hypertension. So the question is, could it be a chronic liver disease? No, because it has suddenly manifested. Could it be renal disease? No. Could it be nutritional? No. So then where could it be losing proteins? And then where you come to an intestinal disease. So protein losing enteropathy looks like a problem, but is a section, renal distinction. And the nephrotic is a very happy cell. So when you get that kind of a story, it's like a nephrotic syndrome, acute onset, abdominal distension, beside this, sickness. Almost say that this is not the protein losing enteropathy. When you look at the story, yes, everything is interesting. So is protein losing enteropathy a diagnosis? In dysphatic syndrome, the diagnosis. So it's not a diagnosis. Because we keep on saying, oh, nephrotic syndrome, nephrotic syndrome.
In general, what is a syndrome? Anything. Collection of certain findings.
And therefore, nephrotic syndrome is also not a diagnosis. But we will never discuss it as anything else. We can comment on that.
Neurological findings like epilepsy and abnormal.
We therefore further classify clinically as possibly typical
Steroid sensitive.
hypertension, non-regular, etc. Therefore, classical elimination. Okay. That is the diagnosis. So with routine using enteropathy is not a diagnosis. So let's see subsequently slides whether it gives you a chance to say what could be called a protein losing, right? And then what is this fever coming? And jaundice coming. We're talking about an intestinal disease.
So fever is like for it, so seems like it was for 3-4 days without any much localization. So it is possibly an intercurrent illness without any etiological.
No jaundice.
What about jaundice? So father said yellow eyes. Did you ask about urine, yellow or no?
Tricolored.
Yeah.
It's not high color.
It is not high color. So we need to confirm. So first of all,
Actually, like the father describes it to be red, not the exact high color, because these are negative. So he has been counseled that he will have red colored urine. So he's told like that.
okay. So that jaundice which the father said eyes are yellow, first of all you have to check whether urine is yellow. If it is yellow, it does two things. One, it confirms there is jaundice and it tells you it's conjugated jaundice. When urine is not yellow, it could still be unconjugated jaundice, but then you have to correlate it that whether in your clinical story you are expecting unconjugated jaundice. When do you get unconjugated jaundice in our clinical practice?
Hemolysis.
Hemolysis. So are you expecting hemolysis in that story anywhere? Is there anything to suggest hemolysis, hemolytic disease or progressive pallor or nothing?
Not on history.
Yeah, not on history. So I will sort of explain that jaundice and decide whether I will confirm it on examination and then take.
But there was fever as well. Because the person said jaundice was there or not there, but and both seem to have got better.
Fever has subsided now.
And I thought about jaundice
If there is a
is
still
also subsided.
It's still there.
It's still there. But if the jaundice is still there, it is definitely there. And there was fever also. So it must be a viral hepatitis level. Right? So do you think it's an unrelated disease? In medicine, generally we would not like to treat unrelated disorder. Okay. In adults, unrelated disorders are very common. You know, every senior adult is diabetic, hypertensive, obese. If you have any simple fever also, you have multiple disorder, comorbidity. Should be good. So do you think it is related to this protein losing enteropathy which we are discussing?
On examination, there are few findings which are
So the probably some of the disorders may have a multi-system problem. Okay. And these are just largely autoimmune. Okay. Something is also metabolic. It brings us the liver and the brain. Okay. Like I said, it's just that kidney and liver. So this looks like a multi-system disorder etiology. And what are multi-system disorder? Autoimmune or metabolic. This doesn't look like metabolic, it must be an autoimmune disorder. So we got further keep using entropy out of an autoimmune disorder. Now, autoimmune could be because of some reason, only auto. And what is that? Like we see in the patient. It's an immunological disorder. We could also look at antibiotics. So we will diagnose today. If not on examination, then they might say this is another right?
So what is that first illness quickly? What do you think?
Meningitis, like the loose stools with meningitis.
So meningitis, why should they have loose stools?
He was told that
No, he was told agreed, but his complaints are not fever, headache, vomiting. His complaints are loose stools. So in relation to loose stools, what infection in the brain?
So the question is, can loose stools cause multiple symptoms? What is very bad. Could it be the same infection viral involving the brain? So does that happen? Viral gastroenteritis virus. Any circumstances? The point is, many viruses in the intestine are localized in the liver square. So begin with even just discharge this. The story doesn't start like meningitis but ends. Thereafter story has ended with TB as well.
LP was not done. You said meningitis. LP was
It was done.
it was done. Normal. That's it. 40%.
So in fact, what sir was asking, sometimes, of course, this story is very incomplete, but sometimes you get a acute dysentery, high fever, loose motions, and such a child may get a seizure, which is due to a toxic encephalopathy. And if the treating doctor thinks it is a CNS infection and you do some LP, you might get some minor changes, but they are not equal to a eventual CNS infection. Okay.
What procedure this child went through?
so in the second admission, OP was done
Scopy was
and samples were sent.
Next, third admission.
Third admission was for the same complaints, and this time CT scan was done, which was suggestive of TB. So he was started on AKT on this. So the report came. After that, for the past 1.5 months, child has been asymptomatic about the loose stools.
When he has come with these complaints since
So now the question is that has jaundice been due to anti-TB drugs?
And also we have kept different.
Usually the jaundice due to anti-TB drugs is conjugated or unconjugated?
Conjugate.
Conjugated, it is hepatic drug. So it will still be hepatic. But because of rifampicin, the color is getting masked. It is orange anyway. So they don't know whether that is conjugated jaundice or not. Okay, give us your DDs and examination.
Three-year-old male child brought with complaints of fetal edema, abdominal distension, fever and yellowish discoloration of eyes with significant history of lymph stools containing blood, requiring 3 admissions for the same. Currently on negative with history of multiple pinpoint lesions over the skin could be a case of inflammatory bowel disease or malaria or AKT-induced hepatitis and thrombocytopenia or CCF.
You know, given a different anatomy of that process, there is a intentional disease, AKT induced, is drug induced disease, and cardiac failure. So multiple organs are involved. Then what is one common disease? So when you bring in all those inflammatory bowel for other layers, AKT induced hepatitis is complication of drug. Why congestive cardiac failure?
On examination, the
On examination, myocardium is involved.
child
Okay, let's see.
Give us the findings.
on general examination, child was irritable but alert and conscious. Radar was 38 per minute, saturation was 100%, HGT was 145, CRT was normal, pulses 25. Head to toe examination, ear was open. The child is 3 years old. Ear is open 1 by 1 centimeter at level. Pallor present, icterus present, bilateral scrotal edema present, bilateral pedal edema, pitting, extending up to the knees, multiple petechiae present all over the body, and abdomen is extended. Anthropometrically, the child fits into acute on chronic malnutrition. On systemic examination per abdomen, abdomen was distended with abdominal girth of 45 centimeter. Liver was just palpable. Spleen was palpable 1 centimeter. Soft and rounded margins. But on percussion, there was no the tympanic note was heard all over the abdomen. CNS tone per reflexes. Knees were brisk. Rest the reflexes were normal. CVS S1 S2 present, soft systolic murmur was present, RS air entry was bilaterally equal and clear.
I think disorders, diminishing finger seems to be a complication of a directional wound. The story that doesn't come like taking away an abdominal TB. The is a more common feature, loose stools is a more common feature. The TB generally has discomfort so possibly the story looks like some chronic recurrent intestinal disorder. That must be you. Because of affecting everything on that, the child is unlikely. Even if there is an inflammatory bowel disease, it is a very close diagnosis, but it is close diagnosis only histologically or isolated. Usually, the abdominal tuberculosis patient looks using to build abdominal dissection and nothing more. Tuberculosis is a recurring story. Abdominal dissection, abdominal TB is intestinal TB. Intestinal TB almost never presents with diarrhea. It presents with often constipation or alternating constipation and diarrhea. Tuberculosis looks very unlikely. Okay, let's quickly go through the medical examination, observation, and so on. If the child cries, we will not disturb the child much. Okay, so somebody without on her takes the mic. That's talking. There's puffiness of the face.
Puffiness as in where?
It's not big or that.
Cheeks, right?
Yeah. Fever edema. There's probably a rash. Abdomen is also looking distended.
Yes, so looks like chronic restriction, not easy just you said mild edema here, skin rash here, and abdomen looks to be distended, especially the upper abdomen. If possible, we'll ask him to lift the shirt and see, but if the child cries, we won't bother them. So then we can do the थोड़ा सा दो बस
Arterist also.
What's something? Bus. Yeah, now just tell us what you find on abdomen.
It's a generalized swelling, protrudent belly, umbilicus.
Is it like ascites or is no ascites? Observation,
It's generalized, so most of the arthritis.
mostly ascites. Where is the umbilicus intestine? It is only the site. It is pushed down.
Yeah.
Why it pushed down? It is not pushed down. There is obviously certainly your spleen or water. So there is something in abdomen. The flanks in sitting position you won't know clearly, but possibly the abdominal swelling is like this more than like this. Okay, but we'll confirm, right? There is some rash there over the skin.
Yeah.
What is this?
So if the blunt swell pressure, then maculopapular is low, then specifically.
It looks like pinkish. Yes.
Not blunt.
Not blanching.
Less than 3 mm. It's pretty of both atrophy. This is possible.
It's gaseous distension.
Yeah, and then it looks like hypotonic abdominal wall. So no fever at all. Just okay, आप ले जाइए. Thank you. So now convince us the diagnosis.
I have kept the diagnosis as inflammatory bowel disease because the child has been having history of loose stools. Then initially it was loose stools, then it was associated with blood stools also. Then it is a chronic history. 2-3 episodes requiring admission. Then the child is malnourished, chronically malnourished. He doesn't look like a 3-year-old child. Then
Yeah, what about the petechiae?
could be drug induced. It could be drug induced right now because he is on AKT. So it could
So, according to him, the yellow eyes and the spots came after the AKT.
no, after fever. That's why I was, and he had spleen also. That's why one like
Thought it was malaria. Or this illness was malaria.
because he had tachycardia, pedal edema, Then tachypnea was also present and abdominal distension. And on presentation, we had just palpable liver on the day of admission. So I thought of failure also. That is why I had written for this admission that he could be in failure.
Yeah, so inflammatory bowel disease seems to be a reasonable diagnosis as one primary diagnosis. It's difficult to explain the other things like fatigue and the fever. Jaundice, at least just now, I was not very convinced looking at the eyes whether there was any liver. So we are little debating on that jaundice bit.
Received transfusion, so maybe the liver has regressed after a transfusion. After admission, we gave him PMC.
Because his hemoglobin was very low.
We had actually sudden drop.
Okay.
In February's admission, it was 10.4. It had dropped to 6 in this admission within a span of 1.5 months. The sudden drop in HB was also there. He had thrombocytopenia also.
So sickle, this is not a story of sickle cell anemia. Sickle cell anemia would have no reason to get edema and all that, nor would they have the thrombocytopenia. That
Series of can cause
that spleen is not so big, and hyperkinesis of thrombocytopenia is very uncommonly clinically symptomatic. It is a lab finding. So you will get platelet 1 lakh 80 thousand. But you should be.
And the Scopy report. So we did a CBC and TS for this child, which was suggestive of hypo and microcytic cells, and large platelets were seen. PTINR was deranged, 2.2 was the PTINR. There was increase in TBL and DBL. In LFTs, OTPT was deranged. TBL, DBL was deranged. Ammonia we had sent because the child was irritable also, and on presentation he had icterus, so ammonia was normal, CRP was increased. Abdominal USG, which was done during previous admission, it did not show any significant abnormality. This is the Scopy report, which was suggestive of in the transverse colon, it showed mucosal edema, longitudinal ulcers, loss of vascularity, friability. Descending and sigmoid colon had loss of vascularity. Rectum showed multiple large, deep longitudinal ulcers with overlying exudate. So skip lesions were present all over the colon. So biopsies were sent from ileum and colon after the Scopy. This was the histopath report, which was suggestive of granulomatous lesions, but it showed necrosis also. So it was diagnosed as COX, and they started on AKT during that admission. And CT scan was done, which was also etiology of COX. So they have started AKT for this child. But today morning we have got the genetic report of the child, which is suggestive of Crohn's disease. Crohn's. We had sent NGS 1 month back, so today we got the report that he is Crohn's. So based on histopathology, they had started on AKT, but now it is genetically proven to be Crohn's.
For the gastroenterologist, the diagnosis is difficult between intestinal TB and Crohn's. For the clinician, they told me it's not so difficult. Because the story is different. But today you depend on evidence-based medicine, and your brain cannot give any evidence at all. Therefore, the one discussing Wonderful answers, whatever I don't know. The story is absolutely not creepy at all. And I recall a child who had similar thing, and the accident of this said is intentional TV. This more of that. These slides were sent to various histopathology specialists who specializes in TB. And they said, yes, a clinician like me, it was typical implementation. We started looking at his skill, right? And he wanted to visit him out. He came from out of town. And when statement that everybody came back again. So he went to the natural college. He said, no, I said, closed. The question is, I know, TB and Hodgkin's lymphoma often go together. I have not seen whether we intestinal organs go together. So the point is, the super specialist is difficult to write. And this is one example where the generalist can override the diagnosis. So the thing will happen. Okay. And one of the investigation was shown from another was shown TV, and finally they were shown related to clinical. This was the result.
So I think we'll stop here, but the main thing is that as we discussed clinically, as Amdekar sir earlier said, the history in tuberculosis is waxing and waning intestinal obstruction symptoms and not just loose motion symptoms, right? So this was with loose motion, blood. So it was more like a inflammatory bowel disease only. And the other things, the jaundice, like at least the bilirubin was 1.2 and 2 point something, which may not even be clinically visible. So that there was some degree of hepatitis, secondary hepatitis, whether it's part of the inflammatory bowel, whether it's a drug-induced, we don't know. And same is about the thrombocyte, right? Okay. So I think we'll stop here. Anything from the online audience? Any comments? Any questions?
No, Rajesh, both cases were excellent and the audio was poor, but we got the gist of the whole thing and very interesting. Thank you very much, Amdekar sir, Rajesh, and all the youngsters who have presented the cases.
Thank you. Thank you. We meet next Thursday. Thank you.
Thank you.
Thank you.